Today I'm going to demonstrate a case of infective endocarditis of the mitral valve on this patient. He is a 61-year-old male patient with history of fever with easy fatigability for 1 month, and he has a positive blood culture for Streptococcus sanguinis, and he has come to our lab for echocardiography. Now, echocardiography plays a key role in the diagnosis and management of infective endocarditis. In the plaques view, we can see very clearly that there are echogenic masses attached to the both mitral leaflets, both the anterior and the posterior mitral leaflets. The one attached to the posterior mitral leaflet is larger than the one which is attached to the anterior mitral leaflet. And most importantly, the points in favor of vegetations is that the masses are attached to the atrial aspect of the mitral valve, that is mitral valve leaflets, the LA aspect of mitral valve leaflets, and the masses are very freely mobile, oscillating, and they are entering into LA in systole and prolapsing into LV in diastole. And this is these are the features of the vegetations of mitral valve. And as we can see that these large mobile masses are resulting in a coaptation failure of the mitral leaflets, and as a result there is significant, in fact quite severe mitral regurgitation, as we see in the color flow imaging over here. As we see, the left atrial diameter is somewhat increased, is 4.58 centimeter, and that's but then a point to note that with this severe mitral regurgitation, we are having a left atrial diameter of 4.6. It is not hugely distended. So the mitral regurgitation is probably of recent onset, relatively recent onset. The size of the masses we can see, this is the larger mass, it is 1.1 centimeter by 0.7 centimeter, and the smaller one attached to the AML is 0.8 centimeter by 0.5 centimeter. And this is a short axis view where we can see the mass, the larger one, just peeping out. These are the Dopplers as we proceed, the transpulmonic, and this is we have taken this, he's having no systolic dysfunction. The LV systolic function is 69% with a LV IDD of 5.6 centimeter. So it's just a high normal LV cavity. In the epilex view, this is another good view where we can see the mitral valve vegetation very clearly, as we can see the highly oscillating echogenic vegetation which is entering into left atrium and then in systole and LV in diastole. The significant mitral regurgitation. This is the PW across the mitral valve, which E by A ratio of 1.9. The tissue Doppler is of course showing raised LA pressure, that's obvious, with the E by E prime of 221. The dense mitral regurgitation jet. This is a transaortic flow. The tricuspid regurgitation shows significant pulmonary hypertension. The TR gradient is 60. And as we proceed, we can see the mitral regurgitation in the apical fourth chamber view also, and with IVC collapsibility of more than 50%. So he's having a infective endocarditis of the mitral valve with severe mitral regurgitation and the pulmonary hypertension with a PASP of around 65. Now, the point to note is that as we have seen in this case, that why this mitral regurgitation is occurring. In fact, this is occurring because the masses are coming in the line of coaptation of the valve leaflets, and there are two mechanisms actually of mitral regurgitation in this setting of infective endocarditis of mitral valve, and that is either the leaflet perforation or coaptation failure of the leaflets, and these usually occur when the vegetations are attached near the middle of the leaflet or towards the apical part of the leaflet. But regurgitation in mitral valve endocarditis can be absent when the vegetation is placed more basally towards the base of the leaflets, so it doesn't interfere with the coaptation of the mitral valve leaflets. And as a result, these cases, are very difficult to discern clinically because there is no significant murmur. So they are usually detected by chance in the echo lab when when the vegetation is situated more basally. I'll just take this opportunity to show you a few similar cases. This is a case of a 39-year-old gentleman presenting with a history of fever for more than 3 months with increasing severity of shortness of breath on exertion. And here we can see that the the aortic valve is thickened with a mass attached to the aortic valve, which is prolapsing into the LVOT in the diastole, and we can see the thickened aortic valve. And here we can appreciate the mass which is attached to the aortic valve and which is entering into the LVOT in diastole. And this is again because vegetations are usually attached to the upstream side of the valve. That is, in case of atrioventricular valves, it's on the atrial aspect, and in case of semilunar valves, it's on the ventricular aspect. So here again, this is a thickened valve which has severe with severe aortic regurgitation, and here we are seeing that LV cavity is dilated. Actually, it was a previously diseased valve, and with superadded infection of infective endocarditis. So this again gives a good view where we can see in the apical 5-chamber view, we can appreciate the vegetation attached to the aortic valve, which is entering into the LVOT in diastole. And this is a severe AR with a p half time of 221 milliseconds. I'll show another case, just a clip of it. This is a case of tricuspid valve vegetation. As we can see, as I told before, that this vegetation is attached to the tricuspid leaflet on the atrial aspect of it. And this is a filamentous vegetation. This is in a case of a 22-year-old male patient with history of IV drug abuse. And similar, this is the same patient. This is a tricuspid valve vegetation in a CKD patient where we can see a thickened, not so mobile mass attached to the atrial aspect of the anterior tricuspid leaflet, giving rise to significant tricuspid regurgitation. And as now the intracardiac devices are very common nowadays, like pacemaker, so infection of pacemaker lids are also quite common. So this is again a case where we can see that a mobile echogenic mass which is oscillating and is attached to the pacemaker lid, and it's is attached to the pacemaker lid, and this is a case of this pacemaker lid vegetation. This has given rise to severe tricuspid regurgitation. So with that, I conclude the presentation of this case, and to briefly summarize what we essentially see in a case of infective endocarditis when a patient is referred to us for echocardiography. The most important point of infective endocarditis is, of course, the demonstration of valvular vegetation, and the vegetation is, of course, attached to the upstrip side of the valve, that is mostly to the atrial aspect of the atrioventricular valves and the ventricular aspect of the semilunar valves. That's the most important point. Of course, there are atypical presentations where we may get the vegetations on the other side, but those are rare, and we can also get some non-mobile vegetations, sessile vegetations, but these are rare instances. So finally, I conclude this session by re-emphasizing the importance of echocardiography in the diagnosis and management, follow-up management of infective endocarditis. So the main purpose of echocardiography in infective endocarditis is to identify the vegetations, define valvular destruction, and characterize invasive complications if present, like abscess or pseudoaneurysm. So there is a modified Duke criteria of 2023, which lists the following echocardiographic findings as major criteria for establishing the diagnosis of infective endocarditis, which are vegetation, of course, the most important, then intracardiac or paravalvular abscess, valvular or leaflet perforation, valvular or leaflet aneurysm, pseudoaneurysm, or intracardiac fistula. And then there, in case of prosthetic valve, one should look for whether there is any dehiscence of prosthetic valve, or in case of valvular regurgitation, whether the regurgitation is new or there is an aggravation of the regurgitation. While doing the echocardiography of a case of infective endocarditis, one must remember a few possibilities of the conditions which can mimic infective endocarditis. And these are papillary fibroelastoma. Then there can be a myxomatous mitral valve disease with a redundant valve leaflet, which is again which may prolapse into the left atrium and mimicking a vegetation. Then there can be a non-bacterial thrombotic endocarditis. These are mainly of two varieties, where we get Liebman-Sachs endocarditis in the SLE patients, and in advanced malignancies we may get Marantic endocarditis. And then again, of course, with prosthetic heart valves, one can have thrombus, which may be mistaken for vegetation. And then, of course, there can be a beam width artifact, or again, there can be some normal valve variants such as Lambel excrescences or calcified nodule of Arantius. So these are the possibilities one should keep in mind while doing the echocardiography for a patient for infective endocarditis. One must remember few possibilities of conditions which may mimic infective endocarditis. So these are the conditions which can come in the differential diagnosis in the echo lab, and which are papillary fibroelastoma. Then there can be myxomatous mitral valve disease, which in which the valve leaflet is redundant and it's prolapsing into the left atrium and systole. And then there can be non-bacterial thrombotic endocarditis like Liebman-Sachs endocarditis seen in SLE patients, and Marantic endocarditis seen in advanced malignancy patients. And there can be, of course, thrombus associated with prosthetic heart valves, which are very difficult to distinguish from vegetations. There can be beam width artifacts, and in certain cases, normal variants like Lambel excrescences or calcified nodules of Arantius can be mistaken for a vegetation. So these are the possibilities which one must keep in mind while giving the diagnosis of vegetation in case of infective endocarditis.